And thank you for this opportunity. I'm happy to be here to moderate this, and I hope that everybody enjoys. So I know that we've already been introduced to our panelists here, so we're just going to go ahead and get started on case number 3, triple-negative disease. So case 3, this is a 55-year-old woman. She presented with a palpable left breast mass. Last screening mammogram was a year ago. She has heterogeneously dense breast on mammography and noticed this mass 3 weeks ago. Physical exam revealed a 2.5 by 1.5 centimeter breast mass, node negative. Breast mammogram and ultrasound revealed that the mass is 2.6 centimeters. On ultrasound, one single level 1 lymph node was noted with loss of fatty hilum and cortical thickening, measuring 0.4 centimeters. An ultrasound-guided biopsy of the breast mass is poorly differentiated, invasive ductal carcinoma, ER 0%, PR 0%, HER2 1+. No family history of cancer with a large family. So really where we want to get started, this is a common presentation for our triple-negative patients. We really want to know, how do you really approach this as a surgeon to see this the first time? Dr. Mamounas.
Yes. So I guess we can get to how we approach it, but let's first discuss the question that you had here about genetic testing. And obviously, if you look at the updated guidelines for hereditary cancer testing, this patient would fit the criteria with triple-negative breast cancer under the age of 60 or under, to be tested. And you can see here are some of the other criteria, age under 45 or less, or 45 to 50 with either unknown or limited family history, second breast cancer, diagnosed at any age, one or more close relatives with breast, ovarian, pancreatic, or prostate cancer. And again, the category for this patient, 60 or less with triple-negative breast cancer. So that patient needs to have genetic testing.
So the next question might be, in a patient like this, when would you really consider a bilateral breast MRI in your patient that presents with a palpable breast mass?
So we talked a little bit yesterday about the role of MRI, and the bottom line is that MRI is not needed for everybody who presents with early-stage breast cancer, but there's some specific situations that's actually helpful. One is if there is dense breast with very ill-defined tumor, we're not sure exactly how much of the tumor exists in the breast. We have multicentric disease. We're trying to rule out connections between different masses in the breast. Invasive lobular carcinoma is one. And younger patients, again, usually have dense breast, so they fall into that category. But also neoadjuvant chemotherapy. If you consider neoadjuvant chemotherapy, MRI is a good predictor of the extent of the disease in the breast and also response in the breast after neoadjuvant chemotherapy. So typically, we get an MRI for patients that have neoadjuvant, or we think they're going to have neoadjuvant chemotherapy. And of course, the category that we always want to get an MRI is if there is an occult disease in the breast. So you present with axillary adenopathy, you know it's breast cancer in the axilla, but you can find a primary in the breast. MRI will find it in the majority of the times. So that's usually how we approach MRI. But not everybody needs to have an MRI.
Thank you. So this patient went on to get a breast MRI and actually was found to have a question of axillary nodal involvement, so a second look ultrasound was requested. Additionally, she did get her genetic testing because she met the criteria, which was negative for any actionable pathologic variants. So the patient undergoes ultrasound and undergoes a core needle biopsy, which reveals metastatic ductal carcinoma, and there was a clip placed at the time of the biopsy. So now we move on to what would we do with this patient. And we know that there's a clear indication in these patients to proceed with neoadjuvant chemotherapy. Neoadjuvant chemotherapy from the medical oncology standpoint, it tells us a lot about the tumor biology, its response to chemotherapy, and also gives us a lot of good options in the adjuvant setting and considerations in the adjuvant setting for residual disease. From a surgical standpoint, I don't know if you want to go ahead and touch on those last 3 bullet points of what you consider to be really important from a surgeon's point of view.
Yeah, of course, and they're very nicely highlighted. Obviously, traditionally, neoadjuvant chemotherapy was used to downstage the disease in the breast and convert inoperable patients to operable, or mastectomy candidates to breast conservation. But also, even if you are a candidate for breast conservation with a sizable tumor, shrinking it with neoadjuvant chemotherapy will allow a more cosmetic lumpectomy. And there, of course, different patterns of shrinkage and growth in the breast with different tumors, but definitely triple-negative breast cancer is one that usually grows concentrically because it's a rapid-growing tumor, and also shrinks concentrically. So it's one of the tumors that you can potentially convert patients who have larger tumors and require a lot of breast tissue to be removed to a more operable and more cosmetically acceptable candidates. But in addition, obviously, an important part of the neoadjuvant chemotherapy is to potentially downstage the axilla. Such in these patients, given the biology and what we see on the ultrasound, probably would require an axillary dissection if surgery would happen up front. But after neoadjuvant chemotherapy, a patient with triple-negative disease, as we will discuss with the new drugs, will have at least 50 or 60% chance that will be downstage in the axilla. And then you can proceed with a sentinel lymph node biopsy, targeted axillary dissection without completing the full axillary dissection, and save the patient potentially morbidity from lymphedema in the future. And of course, the last more operational situation is that you actually have more time to get the genetic testing back to see if the patient decides to proceed with bilateral mastectomy or she's not genetically predisposed, so lumpectomy would be fine. And also allows time to coordinate with the plastic surgeons and set up everything before it's time for the surgery to take place.
Thank you. So we know that triple-negative is a high-grade tumor, and a lot of us don't frequently see pathology slides. So if you wouldn't mind walking us through what we're seeing here, Dr. Magliocco.
Sure. You have a representative image of this particular cancer. In it, you can see that there are areas of confluent tumor cells that are growing. These are high-grade tumor in this case. You don't see any glands. You see high-grade nuclei, frequent mitotic activity. You also see extensive inflammation, a very high number of lymphocytes that are in the background also infiltrating the tumor. So the image here is what we typically think of what a high-grade triple-negative tumor might look like. One should also be cautious in that in pathology, remember that triple-negative is a diagnosis of exclusion, that really it's based on the biomarker that the ER is negative, the HER2 is negative. And there is certain instances, if you were to re-examine those, that some of those tumors might actually get reclassified as being ER positive or HER2 positive, and certainly tumors may have heterogeneity as well. The other thing is that there's certain subtypes of breast cancer, apicrine, other types, that are also display triple-negative phenotype. So when we typically think of triple-negative, we think of this, but there may be some types that are a little bit different. So this is why pathology is always important in terms of having some confidence truly as a triple-negative and that you're not missing estrogen receptor or HER2 in parts of that tumor.
And we know that is really important, particularly since we have all of these agents that are specifically indicated for triple-negative disease, and the way that the pathologist reads that out often impacts the availability of this supply of treatment options. So thank you for walking through that. Now, Dr. Jahanzeb, I don't know if you will walk us through the neoadjuvant trials to see if we can kind of get through and see this new role of immunotherapy in the neoadjuvant setting.
Sure. Can I get the slide advance?
Yes, sure.
Thank you. So Keynote 522 was a randomized trial looking at pembrolizumab added to standard neoadjuvant chemotherapy. Standard in the sense that many use carboplatin. I want to point out that based on CLGB trial, carbo has not become a standard drug in the neoadjuvant setting, but it's not inappropriate to give carboplatin to patients with triple-negative neoadjuvant situation. These patients got chemotherapy every 3 weeks, so not dose dense, even for the AC part. And they got carboplatin either every 3 weeks or weekly at AUC 5 or 1.5 respectively. These were patients who had to have a tumor that was larger than 2 centimeters if they were node negative. But if it was a T1C, then they had to be node positive. An ECOG performance status of 0 to 1. They had to have tissue assessment of PDL1, but PDL1 positivity was not required to go on the study. Pembrolizumab was continued after surgery for balance of the year, and stratification factors were nodal status, tumor size, and carboplatin schedule, whether it was weekly or every 3 weeks. And here are the patient characteristics. It tends to be a younger patient population, so median age was under 50. PDL1 positivity was in majority of the patients, more than 80%. And again, this is 22C3 antibody that we use for pembrolizumab. As we know, that positivity matters by which test you are using. So it's important to know which test was used when you look at and interpret a result, positive or negative. And most people use carboplatin every 3 weeks. Tumor size was T1 or 2 in nearly 3/4 of the patients, and a slight majority was node positive. Here's the definitive pathologic complete response analysis with an absolute difference of greater than 13% between placebo and pembro arms. So nearly 2/3 of the patients had a path CR with a combination of chemotherapy and immunotherapy. You can see that consistent benefit was seen with PCR defined as T0, N0, as well as T0 with carcinoma in situ, but no invasive cancer. This is primary event-free analysis. At 36-month mark, the landmark analysis shows an absolute 8% benefit in terms of event-free survival. And this p-value is highly statistically significant. When you look at PCR by disease stage, you can see if you focus on the maroon bar, which was the placebo group, that bars keep getting shorter with increasing tumor burden. And the delta between the two bars, two pairs on the right, is greater than the pairs on the left. So the absolute benefit is greater with increased tumor burden. And PCR by lymph node involvement, negative versus positive, you see bigger delta in node positive patients compared to node negative. And note how whether you're node negative or positive, your PCR rate is identical in the pembrolizumab arm, but not so in the placebo group. When you look at expression level of PDL1, so under 1, which would be 0, there's still a delta, which it says 18, but by my math, it's more like 15 between the placebo group and pembro group in PDL1 negative patients. That shows you that PDL1 is not really a perfect biomarker. It's not like ER or HER2. So the benefit is not 0 in PDL1 0 patients. In fact, relatively speaking, again, if my math is correct, 30 to 45 is a 50% improvement in PCR in that group, whereas the percentages are smaller, interestingly, of this delta if you march to the right. But if you notice, the green bars keep getting taller, more positivity matters. So there is a gradation of efficacy with more positivity of PDL1. And also note that the maroon bars are far taller on the right compared to PDL1 0 group in the placebo group, which means that PDL1 positive tumors are also more chemosensitive, which is interesting. Now, when you look at the EFS by nodal status, again, the green lines are pembro groups, and the top ones are node negative. You notice that the lower line, which is lower green line, overlaps completely with the upper maroon line, which means if you are node positive, you do just as well with the addition of pembro as you would have done with chemo alone if you are node negative, because those two lines are completely overlapping. And hazard ratios are 0.58 and 0.65 respectively. Okay, back to you.
Thank you. So moving back into our case, we know that our patient had the negative genetic testing. She had the second look ultrasound with additional lymph node biopsy confirming that she has N1 disease. So the patient starts neoadjuvant chemotherapy per the keynote 522. So now we move into the side effects of this immunotherapy. We know that immunotherapy has different side effect profile than cytotoxic chemotherapy. Most specifically, we look at this in our endocrine function. We see a lot of that and a lot of autoimmune activity. We know that from the I-SPY 2 trial that we have some AEs of special interest, including hypothyroidism, hyperthyroidism, as well as adrenal insufficiency. Hepatitis, pneumonitis, and colitis were also noted, and some degree of dermatitis can also be noted. So let's move through this a little bit more. This is looking at the treatment-related AEs in the combined phases. And this is still, the maroon lines are the pembro with, or the placebo with chemotherapy, and the teal lines are the pembro with chemotherapy. And you can see with the toxicities that we're looking at here, for the most part, they are more or less equivalent. These are a lot of the side effects that we see with cytotoxic chemotherapy. A little bit of the ones with difference would be rash, that we do see a difference in rash as well. But you can see that overall, the grade of these is quite manageable with grade 1, grade 2. However, there is a little bit of neutropenia noted in both that can be potentially worse, grade 3, grade 5. So I think it's important also to note that a lot of these patients are, they're getting quite a bit of chemotherapy. A lot of this shows from prior studies in the metastatic setting too, that we can know that our patients who have been heavily pretreated tend to have a lot more of those toxicities of CBC changes. So looking a little bit more at these, you're looking now still through a lot of what we see with cytotoxic chemotherapy. Any grade, about 50% of patients did have some degree of toxicity, but the serious toxicities you actually noted were not significantly higher in the pembrolizumab arm. But when we talk about the immune-mediated AEs, I think that this is really where we need to understand a little bit better, because it's not necessarily a silver bullet. A lot of my patients will come in and they're asking specifically for immunotherapy because they think that that's going to fix all the problems. But a lot of times it can cause some problems. Fortunately, they tend to be noticed early and treated well, but we know that there is an increased risk of infusion reactions, thyroid disorders, skin disorders, and adrenal insufficiency. So we really look for all of this with our routine screening, and we're talking to our patients about the possibility of these toxicities on our routine evaluations. You can see that thyroid disorders tend to be the most common that we see. It is also reported actually in the placebo arm, which says something probably for what happens to patients' just bodies as they go through treatment. But we know that that is more common, and we follow that closely. When we look at the toxicities and we look at chemotherapy, we know that almost all patients develop a toxicity of some sort from cytotoxic chemotherapy. We have very well-described AE profiles for cytotoxic chemotherapy, and we know that very few organ systems are affected. We know bone marrow is affected, we see that routinely, and we follow LFTs and other things that we anticipate to be minorly out of range, but we anticipate those. And we know that what the time course of these toxicities are, and that's very well established. What's different is with immunotherapy, we don't have all of that well-established information. It really is more unpredictable. Most patients tolerate immunotherapy without significant toxicity, but the potential is there. And there is a very variable AE profile. Every patient has their own risk, very specific to them, and it could be including many different organ systems, or it could be maybe one or two at a time. It can affect absolutely any organ system, and the time course is variable. And we can even see that patients develop toxicities more than a year after they've completed treatment. We know that any of the organ systems can be affected, from endocrine, which we often see and we're evaluating for routinely, as well as respiratory with pneumonitis. We have seen episodes of hepatitis from this, nephritis, arthritis, and then neurologic, you can also see some changes, eye changes and eye irritation. We take this very seriously and make sure that we have ophthalmology on standby for consultation. We evaluate cardiac function. A lot of patients do develop some degree of colitis or GI toxicities. And then most often, I would say that we see a lot of skin rashes, psoriasis, and other things that can be irritating to the patients, but fortunately can often be treated well. When you're looking at the toxicities with these checkpoint inhibitors, this is just showing the variability of the timing. It can occur even after a year from the end of the treatment, and it can be a lot more variable with these new novel combinations that we're looking at. As we start to introduce other combination drugs and other targeted therapies in combination with checkpoint inhibitors, I anticipate that we're going to continue to learn more about how this will work out for the patients and their potential toxicities. So the majority of them are mild to moderate. The severity can be completely asymptomatic to life-threatening in some cases, so it is important to have very prompt recognition. And most of them are reversible with steroids. However, some of them can be lifelong. You can have immune-mediated diabetes and a lot of the other endocrinopathies that require lifelong therapy. But fortunately, we know what to do with those and we can manage them. But it's really important to educate the patient so that if they were to present to an emergency room, they can say, I am taking this immune activating drug and this is what the potential toxicities are. Because a lot of patients present to an ER, the emergency room physician doesn't really know what to be looking for to figure out what the cause of that toxicity may be. So moving back into our case, the patient goes on, receives her neoadjuvant chemotherapy. Following chemotherapy, she's had an excellent clinical response by the end of the cytotoxic portion. An end of treatment MRI demonstrates complete imaging response in the breast and in the axilla. So now, if you wouldn't mind telling us what your surgical approach for this patient at this point would be, and also discussion regarding the treatment of the axilla.
So when it comes to the primary breast tumor, this is a 55-year-old who doesn't have any genetic predisposition. So her risk of contralateral breast cancer is not that elevated compared to the average breast cancer patient. So with this response, if the patient is desirous of having breast-conserving surgery, I think would be a very good option for her. And obviously, if she decides to have mastectomy, I think that's not unreasonable, but that's something we cancel in terms of what the expectations are, essentially mostly prevention of contralateral breast cancer or ipsilateral new primaries. So she's a good candidate for breast conservation. Obviously, we have to localize the area in the breasts before surgery because obviously the tumor is now gone, so we'll localize the clip. And then as far as the axilla goes, again, as we discussed yesterday, given that we see a very good clinical response and normalization of the nodes, she's a candidate for what we call now targeted axillary dissection, which essentially is removing the clip node that was positive before, as well as any sentinel lymph nodes that you can identify with mapping, either blue dye, isotope, or both. Typically, we do both. And that potentially will reduce the morbidity in the axilla, assuming that the sentinel lymph nodes are negative. If the nodes are still positive, though, I think a completion axillary dissection is still considered the standard of care. So we have some slides here. As we've discussed, we looked at the lymph node, sentinel lymph node biopsy after neoadjuvant chemotherapy back in NSABP B27, a retrospective study, and showed reasonably good false negative rates. But prospectively, this has been now studied in 4 trials, 3 of which are shown here, where patients with positive lymph nodes before neoadjuvant chemotherapy underwent neoadjuvant chemotherapy. If the nodes became clinically non-negative, then they had sentinel lymph node biopsy and then completion axillary dissection to see what the false negative rate was. And the false negative rate was a little bit higher than we have expected. We hypothesized that about 10% would be reasonable, and it was about 13% overall. You look at it in different trials, it varies a little bit. In the Canadian trial, the middle trial, it was a little bit lower, but in that trial, they did also immunohistochemistry in the sentinel lymph nodes, so they increased the sensitivity of identifying a positive sentinel lymph node. But the overall, in a meta-analysis subsequently performed, is about 13%. But what we saw in these trials also is that as you remove more sentinel lymph nodes, the false negative rate drops to single digits, as you can see with 2 or plus in the Sentina trial, 9.6%, in the Canadian 2 or plus sentinel nodes, 4.9%, and in the Z1071 with 2 sentinel nodes, 8.7%. But then, when the clip node was included in the specimen in the 1071, we saw that the false negative rate dropped to 6.8%, and now subsequent studies targeting the node, the clip node, has shown that the false negative rates dropped to about 3 to 5%, which is very, very reasonable. It's even less than the upfront sentinel lymph node biopsy. So we think that's a very safe approach of targeting the axilla and saving the full axillary lymph node dissection. So these are the data with the clip node that I discussed before.
So moving back into our case with our patient, the patient goes on to undergo surgery, and there is a residual 0.5 centimeter residual invasive ductal carcinoma in the lumpectomy specimen. But 0 out of 3 sentinel lymph nodes were positive, with one of the biopsied lymph node also included in that specimen. So now what would your recommendation be in the postoperative setting regarding radiation for this patient?
Yeah, so that's actually a very good question that we've asked already in a clinical trial. Based on data from back in the NSABP, B18 and B27 were identified predictors for local regional recurrence after neoadjuvant chemotherapy, and sterilizing the lymph nodes if they were positive before but negative after put the patient in a better prognostic category in terms of local regional recurrence. So the NSABP B51, which is a trial that you see in the bottom, essentially asked the question, if you had positive nodes before and you sterilized the lymph nodes after neoadjuvant chemotherapy, do you need comprehensive radiotherapy to the regional lymph nodes or not? Traditionally, obviously, the standard would be to radiate the breast if you had lumpectomy, and regional nodes, which include usually the supraclavicular internal mammary and low axilla. And if you have mastectomy, essentially chest wall radiotherapy and regional nodal radiotherapy. So the B51 trial is now completed to accrual, and it's in follow-up. We're expecting the results hopefully soon, but it's going to be a couple more years. I think the median follow-up is actually almost 3.5 years now. But it will answer an important question. Can we spare patients radiotherapy if the nodes became negative after neoadjuvant chemotherapy? In other words, can we treat them as non-negative? The first trial, the Alliance 11-202, asked a different question. Asked the question, if you did all that in a positive lymph node patient before neoadjuvant chemotherapy, you did a sentinel lymph node biopsy, but now the sentinel lymph node is positive, do you need to complete the axillary dissection or not? Assuming, of course, that the patient then will receive comprehensive radiotherapy because it's still node positive after neoadjuvant chemotherapy. This trial is about to be completed in terms of accrual, and also will answer a very important question. It may actually help us take away the axillary dissection even in that group of patients that persistently are positive after neoadjuvant chemotherapy, which I think can save patients a lot more morbidity.
I know that that's a hot topic that's often brought up in our tumor board in the discussion of whether or not these patients need to go back to surgery and exactly what to do with them. So it will be exciting to see how that plays out. So in the adjuvant setting, we know that we like neoadjuvant chemotherapy because it gives us a good idea of what our options are in the adjuvant setting for these patients who do not have a complete response. So I don't know if you will talk us through the adjuvant role. I know you like to take control there, so you can take that and march us through the adjuvant role of continued treatment, please.
Yes, so this was a Japanese study, CREATE-X trial. We all struggled with the patient who has residual disease after neoadjuvant. Actually, in the old days, many of the oncologists would split the chemotherapy, give 4 cycles before and then 4 cycles after to circumvent facing that patient, saying, well, you still got 4 more coming. But now that we give everything up front, it becomes more of an issue because patients, as one of my professors used to say, when the data are not there, patient still is. So patient still wants to know what is she going to do next. So there have been other negative trials, but this study actually showed positive results in the overall population of patients. But when you looked at node negative versus, looked at ER negative, which were triple negative patients, because everybody was HER2 negative, versus ER positive HER2 negative patients, the benefit was confined to triple negative population, where the difference was actually 13%, as opposed to here you see about a 6% advantage of using capecitabine versus no further therapy. And capecitabine was given in what we now think of as mother-in-law doses, full doses that no one uses, of 1,250 milligrams per meter squared twice daily. We generally use much lower doses, but this is a curative setting, so we don't know whether we have that kind of flexibility in a curative setting or not. So right now, this has been accepted as a standard offering to patients who finish neoadjuvant chemotherapy and have residual disease. How it will change based on what I showed you in Keynote 522, or whether patients, some of them will be BRCA mutated and will need a PARP inhibitor. So now we are in this very confused territory of how the standard of care has shifted in patients with residual disease after neoadjuvant therapy. Another trial by Southwest Oncology Group is actually looking at patients who have residual invasive tumors greater than 1 centimeter to randomly assign them pembrolizumab or observation. And a question can be asked, why are we observing them when we could have offered them capecitabine? But at any rate, sometimes we take some liberty in a clinical trial to learn something new. Otherwise, one can say that the control arm could have been capecitabine in this study.
Thank you. So our patient received 6 months of capecitabine followed by pembrolizumab. 12 months later, unfortunately, the patient presents with liver, lung, pleural, and bone involvement. She still has an excellent performance status, but scans were prompted due to mild shortness of breath with exertion. An echocardiogram was normal. CT angio revealed no evidence of a pulmonary embolus. And the pleural effusion was tapped, revealing ER 0%, PR 0%, HER2 negative, Ki67 of 25%, PDL1 20% with CPS. So I know that we've already discussed a little bit about the different standards in testing for PDL1 positivity, but if you wouldn't mind marching us through really what the importance of that testing might be and how we would use that clinically.
Yeah, it's a very interesting topic, PDL1 evaluation. It's the first mark. You have to remember, we're assessing the same target. We're looking at PD1 and PDL1. That's the target of the drugs. But we have multiple ways to measure it. There are multiple different commercial assays that are available, and they're trying to measure the same thing. But you're getting different results. So you have the 22C3 that was used fairly extensively initially. That was based on a DACO platform. It was actually an outdated platform when it was launched, so very few labs had that particular assay available, making it challenging to launch it. So that was the 22C3, particularly in the US, where the bulk of American labs used the Ventana Roche systems, and Roche had a different product. They had SP142, and then they have another antibody called SP263. And so this prompted that there are all of these multiple clones and different machines that do the staining. And this puts pathology departments at a challenge in that you need to use different clones, different machines. On top of that, there's different scoring systems for each of the clones. So in some of them, you're looking at the immune cells. So in SP142, you're trying to measure the immune cells, and a cut point is 1%. In SP263 or 22C3, you're looking at multiple systems where you're looking at the tumor cells, or you're looking at a combination of the tumor cells and the immune cells and adding them together. And on top of that further is that each tumor site has a different approach as well. So pathologists are not necessarily just dealing with breast, they're also working with gastric, with esophageal, with bladder, and with all of these other sites where these markers are also present there. So so there's multiple studies from pathologists looking at how these tests compare to each other, and we're getting a good idea about how they compare to each other. So the SP142 test is very much looking at the immune cells, and it was always considered sort of the black sheep of the family of PDL1 tests, in that it tended to stain immune cells well, but not tumor cells. And it was always an outlier, that it always showed sort of lower staining than the other antibodies. The other ones were very similar, so they tended to be substantially the same, that you get similar scores from the 22C3, the 263, and the other one, the name evades me right now, but they tended to be better together. And interestingly, most recently, the SP263 shows higher staining than most of the other ones as well. So this study here that's shown here is actually showing you sort of an inter-stain comparison, where you can see 3 different antibodies compared to each other and how you'd see positivity. So you can see substantially in the proportion of the cases, they all are positives. However, there's a subset where if you used one staining, you might classify a case as being positive, whereas if you use the other, you classify it as negative. So I think that's one of the points here. And it's also a concern for pathologists when you're designing studies, what assay are you going to use and how are you going to do the cut points and perform that. To add a layer of complexity to this, to not confuse it more, is if you consider a drug like Keytruda, it's also got other indicators that are independent of PDL1. For example, microsatellite instability, which is a pan-tumor indication. So you could be PDL1 negative and have microsatellite instability high, and you qualify on that. There's also look now at tumor mutational burden and how it may be related to the immune response and so on. So I think we're sort of stuck with these antibodies and these scoring systems for now, so we have to deal with them. But going forward, there's a lot of work being done. How can we make these systems more reproducible, perhaps using digital pathology and imaging, multiplex analysis, and also looking at molecular markers as well. So unfortunately, that's the state of affairs in PDL1 testing.
Thank you. And I know that it was really a big concern for us as we were initially looking at IO in the metastatic setting. Which test were we using? Were our pathology labs equipped to be able to do that? So really, this is where it played out. So I don't know if you'll walk us through some of these metastatic studies with immunotherapy. And this actually was really important in figuring out which patient was a candidate because these tests did vary.
So this study is important historically because we had nothing but chemotherapy for triple negative disease forever. I mean, PARP inhibitors don't count because with BRCA mutation, you can be ER positive or ER negative. So this was the first study to bring immunotherapy into breast arena. And this was a randomized trial of more than 900 patients randomized 1-to-1 to receive atezolizumab or placebo with a nab-paclitaxel chemotherapy backbone with the co-primary endpoints of PFS and overall survival, secondarily overall response rate and duration of response, as well as safety and tolerability. And here's the bottom line. The first results that came out and led to the approval are shown here, where in the intent to treat population, it was a negative study with PDL1 positive population. There seemed to be a 10-month survival advantage, which with subsequent follow-up was shortened to about 7 months, but still persisted. And again, it's important to point out that 41% of the patients were PDL1 positive here, not 82% as I showed you in Keynote 522 because of what we just heard, assays in one word. So when you have a 1% positivity by 22C3, that's not what this is. So that's why the cutoff for 22C3 for positivity has been accepted at 10%, because about 10 plus PDL1 positivity is seen in about 38%, which is close enough to 41. And we'll get back to that. So FDA approved it in March of 2019. And then there was a confirmatory trial, Impassion 131 with paclitaxel instead of nab-paclitaxel, with similar design but 2-to-1 randomization this time and somewhat smaller study than the previous one. And this was completely negative. So why is this negative and the other one positive? One answer can be statistical fluke, because obviously there's margin of error in statistics. Another explanation that has been thrown about is that you use steroids with paclitaxel that will impede the efficacy of immunotherapy, but you don't use steroids with nab-paclitaxel, and maybe that's the right type of chemotherapy to use with immunotherapy. Be that as it may, the indication was pulled. So just a story that was exciting and became unexciting at the end, but needs to be mentioned historic interest standpoint, because oncology is full of excitement followed by disappointment if you look at our history. Okay, so getting to metastatic disease along those lines, so atezolizumab is gone from metastatic setting in triple negative, but this study looked at Pembro, Keynote 355, again, adult patients had to have PDL1 testing, but PDL1 positivity was not required, and they had recurrent or metastatic triple negative breast cancer, completed treatment with curative intent at least 6 months prior so that you don't get those very bad actors who relapse within 6 months. ECOG of 0 to 1, life expectancy of at least 12 weeks at the time of randomization, and adequate organ function. They were stratified by chemotherapy type because there were options to give taxane or gemcitabine carboplatin at the discretion of investigator, and stratified by combined positive score of greater than 1 or less than 1, prior treatment with the same class of chemotherapy in the neoadjuvant or adjuvant setting, yes versus no, and they received this treatment until progression of disease or in unacceptable toxicity. So this is the PFS curve here showing a 2-month advantage in PFS with hazard ratio of 0.82, and subset analysis showing that patients with taxane actually had a better hazard ratio of 0.51 compared to gemcitabine carboplatin of 0.77. But again, it's important to realize that that doesn't mean that carboplatin, gemcitabine are an inferior chemotherapy regimen than single agent taxane. It just highlights the fact that second drug added to first drug makes more impact than a third drug added to a doublet, law of diminishing returns. So because these are relative differences, you would have predicted that the difference would be lower when it's added to a doublet rather than a single agent. But the important point here is that all subgroups seem to benefit except for those who had relapse within 12 months. So those are bad actors, like I said, those patients don't do well. Overall survival at final analysis, here you see the best separation of curves when you look at 10% positivity or greater on the left-hand side, and then the middle one is everybody who was 1+ positive or above, and on the right-hand side intent to treat population. So the largest difference of 7 months is in 10% cutoff. This was updated at San Antonio with these subset analyses by cutoff, and that's maintained, and 10% is considered acceptable dividing line rather than 1% that we had seen with the atezolizumab because of the different assays used. Here again you see subset analyses, and note how when you make a subset smaller and confidence interval wider, it will reach and cross 1. So at the bottom you see 10 to 19 as a separate group versus 20% or greater, and both touch or cross unity. They have to be combined to shrink the confidence interval to get the statistical significance that you saw on the previous slide. So November of 2020, more than a year ago, pembrolizumab was approved for use in metastatic disease. And again, an editorial comment, carboplatin gemcitabine does not cause alopecia, so women who don't want to lose their hair, I use that as a preferred option in them rather than the taxane.
So in our patient, she actually goes on to receive carbo, gem, and pembro in the first line for triple negative. I would say, just as a quick editorial also, that most of us, in fact, uniformly, we would all agree that in the first line, if a trial is available for a patient, that would be the best option. If a patient qualifies for a trial or one is available at the institution, that's really what we would prefer for our patients in the first line. But we know that there are so many new and exciting options for patients, and this is why we push onto trials so that we can better understand what these options really are and how this will play out. There are antibody drug conjugates, which seem to be highly favorable. We know that sacituzumab is one of those, and we've got the ASCENT trial that's really going to be telling us more and more about how this plays out in the triple-negative space. We also have ladiratuzumab vedotin, and that's being evaluated in combination with pembrolizumab as first line and as a single agent in later lines. And then we know that PARP inhibitors in the triple-negative space have been important in our patients with germline BRCA mutations, with olaparib and talazoparib that are currently approved in the metastatic setting, and then we have really hopeful data coming up with the olaparib in the adjuvant setting. So when we talk about antibody drug conjugates, we know that there's slight variability on where these drugs may drop their payload, but overall this is the mechanism of its action. So the binding of the antibody to the antigen, and then in some cases it's endocytosed before it releases its payload, or in the tumor microenvironment, it might cleave the linkers, in which case the payload is dropped there. But in general, you have this endocytosis and then the degradation of the linkers inside the lysosome that then release the payload, and it leads to apoptosis and cell death of the cancer cell. And there is a bystander effect, which is really exciting because we know that there can be heterogeneity in tumor cells. So they may not all have that antigen that the antibody binds to, but we're hopeful that there is a possibility for that payload to cross the barrier and kill the surrounding cells. So looking into what we have available in the triple-negative space, I'm going to go back to Dr. Jahanzeb to talk a little bit about sacituzumab, and we'll go through a couple more of the ADCs that are available for patients.
Thank you. So with apology to those who suffered through the breakfast talk, I have already spoken extensively about this drug, but sacituzumab govitecan, and if anyone cannot say that, should not be prescribing it, is an antibody drug conjugate and has three parts like any ADC, which is the antibody, the payload, and the linker. It has a high drug-to-antibody ratio of 7.5 to 1. First, there was a single-arm, open-label study with 110 patients, which were all triple negative and had received 2 prior lines or more of therapy before they were randomly assigned. Sorry, not randomly assigned, it was just a single arm. And here was the result, a 33% response rate. And that led to the larger confirmatory trial that I already showed you this morning that showed a clear-cut PFS advantage of 1.7 versus 5.6 months, and overall survival advantage of 6.7 versus 12.1 months. And response rate difference was even more dramatic, 5% versus 35, 7-fold increment in response rate. We seldom see that in later lines of therapy. Adverse events were manageable, myelosuppression being one prominent side effect, and diarrhea and nausea the other. There's also fatigue, but when you look at the grade 3-4 columns, these drop to single digits. And they were lower in the control arm, where patients could get either eribulin, gemcitabine, vinorelbine, capecitabine. Now, for hormone receptor positive metastatic breast cancer, there's a phase 1/2 basket trial, 3rd line or beyond. Same dose, day 1, 8, Q21, continued until progression with endpoints of response rate by RECIST, duration of response, progression-free survival, overall survival, and safety. This other drug, datopotamab deruxtecan, again, I rehearsed it this morning. It's also an antibody drug conjugate. As you can see, that the payload is the same as the drug that we have approved now in the HER2 positive space, which is using HER2 as the molecule that's being sought by the antibody. But here it's TROP2, which is the same as what I've just shown you for sacituzumab govitecan. And Protean is a trial that's a pan-tumor trial with subsets, buckets, one should say, of lung, breast, triple negative, as well as hormone receptor positive in a separate bucket, and other tumor types. So primary objective here is safety, tolerability, and secondarily efficacy, pharmacokinetics, and anti-drug antibodies in adult patients. As you can see, highlighted triple negative box because this was presented at San Antonio meeting. And there are some little things on this slide. Since this is not my slide, I can criticize it. Progressive disease in 8 patients, so I count only 4 bars going up. So I've been counting bars and not satisfied with the way these numbers are displayed. Be that as it may, the overall response rate is 34% in this group of 44 patients. But when you look at patients who were treatment naive and had measurable disease at baseline, those 27 patients have a response rate of 52%. Here, and again, it says progressive disease in 4 patients, and I see only 2 bars going above the line of 20% increase in size. So it's an active drug in conclusion, but the numbers will change with closer scrutiny in the future, I hope. Then there was a phase 1 study with ladiratuzumab vedotin in patients with heavily pretreated metastatic triple negative breast cancer. This is a humanized IgG1 monoclonal antibody that targets LIV1 zinc transporter, which is very commonly found in triple negative patients. These patients had, again, 2 or more prior therapies in the metastatic setting and had to have LIV1 expression. And 614 screened patients had 90% positivity, and moderate to high positivity was seen in more than 2/3 of the patients. And here's the waterfall plot with confirmed overall response rate of 25% in this group of patients. So again, another active compound. Now, I mentioned trastuzumab deruxtecan in HER2-positive patients where it's already approved for use. But if we really think about it, at the end of the day, these drugs are chemotherapies. We may use target-seeking antibodies, but the payload itself is chemotherapy. So one can reasonably hypothesize that if patients weakly express HER2 on the cell surface, which is 1+ or 2+ by immunohistochemistry, and they invented a new category of between 0 and 1+ positive, which is like very faint positivity in a few cells that does not rise to the level of calling it 1+. And one must add that they all have to be FISH negative, so they can't have HER2 amplification, otherwise they would not be called HER2 low. So in these patients, testing this drug makes sense in its regular doses compared to investigator's choice of chemotherapy, which has become a very popular trial design. And confirmed overall response rate of 50% was seen. So if this pans out, this will be a huge subset of patients to target with this drug. And 50% response rate, to put this in perspective, in this line of therapy compares favorably with 33% response rate or 35% response rate that I've shown you for sacituzumab govitecan. So is this deruxtecan a much more potent chemotherapeutic option than govitecan? You know, that remains to be seen, but this is very encouraging for patients to have another option. Phase 3 trial is currently ongoing.
So getting back to our case to finish up and summarize, we have a 55-year-old postmenopausal woman diagnosed with a T2N1 triple negative breast cancer, negative genetic testing at diagnosis, receives neoadjuvant chemotherapy per Keynote 522 with an excellent clinical response, and at definitive surgery has 0.5 centimeters of residual disease in the breast with no lymph nodes involved, including the biopsied node. She receives adjuvant radiation, capecitabine, and pembrolizumab, and 12 months post-completion of curative therapy, the patient presents with widespread metastatic disease. We have a lot of options on the horizon for our metastatic patients, which is really exciting. A lot of them are very promising. So I hope that we scratch the surface a bit of what is available for these patients. And now we'll address some of the questions that have come through. So I have a couple of questions. The first one that came through is neoadjuvant treatment standard of care regardless of size of the breast mass? And I think that this is a good question. We deal with it in HER2 as well because it now impacts your adjuvant care. Really, what is your cutoff when you're seeing a patient for the first time as a surgeon? When do you really refer them over for neoadjuvant care?
So that's a good question. And in general, I mean, at least in our institution, we consider neoadjuvant chemotherapy for anybody with T1C or larger tumor for triple negative and HER2 positive patients. I think the big decision is we ask the oncologists, would you do something different if the patient was treated in the neoadjuvant or the adjuvant setting? And if the answer is I'm going to give the same chemotherapy, they would prefer to give it as neoadjuvant for the reasons that we alluded to before. But if the answer is, let's say it's a 68-year-old patient and has a 1.5 centimeter tumor, and the oncologist says, well, if the nodes are negative, then I may go with TC times 4 or 6 versus an adriamycin-based regimen, then sometimes we'll go ahead with surgery first, particularly if we're reasonably certain that the nodes are negative. Biaxial ultrasound and the tumor can still undergo a lumpectomy up front. You may lose the issue of what you treat with the adjuvant setting if there's a residual disease, but that sort of offsets the potential risk of giving a more toxic chemotherapy where you may not need it. So that's about the time. So for T1A and T1B, of course, we typically would do surgery first. Particularly some of these patients may have component of DCIS and the invasive tumor may be smaller. But that's how we approach the patients. But I mean, the point is well taken that in the current situation where you can give effective adjuvant therapy, I think knowing whether the patient responded or not is important. And it used to be, as MJ mentioned, it used to be that you gave neoadjuvant chemotherapy with the hope of PCR, but you didn't want to face the patient that didn't have a PCR because you had no options. But now I think we have options, and we set these expectations up front with the patient, saying that we're going to give you neoadjuvant chemotherapy. If you have a PCR, it's great, but if you don't, we still have options to give you, and I think it's a kind of win-win situation.
Right. So that actually leads into a question that we got 3 times about that. When you have residual disease, are you routinely offering Xeloda and Pembro in the adjuvant setting for those patients, MJ?
Oh, sorry. I don't want to use 2 mics, that's right. So it was easy previously, now it's complicated because now we have patients who have Keynote 522 type approach, and of course you are committed to finishing a year of pembrolizumab, so the option of stopping Pembro and putting them on Xeloda is of course not correct, but whether you add Xeloda to pembrolizumab is a data-free zone type of situation where we have no data. We know it's likely safe because we give Pembro with all sorts of chemotherapies. So it's a discussion with the patient. We say we used to do this and now we do this, and whether we can combine the two requires a clinical trial, but we don't have any. So I would, in my mind, assess the degree of residual disease, age of the patient, many other factors, and discuss it with the patient, emphasizing that there are no data,
right,
but I want to do everything for you. I sometimes say to patients that no matter what I do, there is a chance of relapse, and regret and relapse are very bad combination. So consider this your anti-regret therapy.
Right.
That you don't regret not
I agree.
trying. Yeah, exactly.
I absolutely
If I make a comment real quick, that I think in the SWOG 1418, it's interesting because patients typically in the beginning, we said you have to give capecitabine before you enter the trial, but also later on, the trial was amended to allow patients to enter the trial, declare if they're going to get capecitabine or not.
Okay.
So we have data with the combination, but it hasn't sort of been published or presented. But there will be safety data, and so far, I mean, we haven't heard anything adverse for these patients. So it's possible that you can do it in combination as well.
I think in clinical practice, it's being done quite a bit, and we know that it doesn't really have overlapping toxicities. We're pretty comfortable with that. So on that, moving into the metastatic setting, so this is kind of a two-part question. We know that there's the shortage of Abraxane. So what would your alternate regimen be for first-line metastatic triple-negative breast cancer? Would it be paclitaxel and pembro? And if that patient was PDL1 less than 10, would you recommend, what would you recommend in the first line? So two separate questions, but both in the metastatic setting.
Well, so the second part I would answer first. Less than 10, greater than 10 has to be then specified by the antibody. So if it's pembro, it has to be 22C3 and the cutoff is 10. So that's the easier answer. And in the first part, which chemo you would give, like I'd mentioned, it would be dependent on the patient type. If somebody says, I absolutely cannot lose my hair, then taxane is off the table. If somebody says, I don't want too many side effects, then I would use single agent therapy because doublet therapy has more toxicities. So it really depends on the patient. There's no right or wrong regimen. I would present both to a patient.
Perfect. I thank you all for your participation, and thank you much.